Hello, I'm Dr. Nora Volkov, and I direct the National Institute on Drug Abuse. And it's a pleasure for me to speak to you about the advances that have happened in our understanding of the effects of drugs in the brain and addiction, as well as the treatment and prevention interventions. And with that, I'm going to share my screen. Science that has been done both in humans and in laboratory animals have established that drugs that are able to increase dopamine in reward areas of the brain, such as the nucleus accumbens, are actually necessary for their rewarding effects and can produce addiction. The way that drugs increase dopamine in the nucleus accumbens varies by the type of drugs, but they all have the same component. They increase to a lesser or greater extent the amount of dopamine that is released in the nucleus accumbens, and this in turn determines why some of the drugs are more addictive than others, and why the addiction escalates faster with some drugs like methamphetamine than with others such as marijuana. However, it is also clear from epidemiological studies that while drugs are necessary to produce addiction, and by addiction, I describe the state, the condition, the chronic condition in which the individual has an enhanced drive and motivation to take the drug and an inability to self-regulate those intense desires, leading to the compulsive consumption despite its adverse consequences. That behavior arises from the effects of repeated drug administration on the brain, modifying multiple neurocircuits that then result in addiction. But what research has shown us is that not everybody that gets exposed to drugs repeatedly becomes addicted to drugs. So an area of research has been to try to understand what is it that differs people that become addicted from others that do not. And there are overall two large areas that are involved in that distinction. One of them are biological factors, such as your genetics. Genes play an important role in vulnerability to addiction. And it is estimated that at least 50% of the risk of addiction is heritable. Also, it is clear that exposure to drugs, particularly during young adulthood, adolescence, is much more detrimental in facilitating the transition into addiction than exposure to those same drugs later in adulthood. And that again reflects biological factors. And the second component is the clear recognition that environmental factors are crucial in determining the vulnerability or the resilience to drug use. And that individuals that are exposed to environments that are very stressful with neglect, social deprivation, abuse, access to drugs, violence, are much more vulnerable to becoming drug users and then to transition into addiction. Whereas those individuals that are born into supportive social environments and with multiple opportunity are less likely to do so. And through research, we again are starting to understand how is it that genes influence the way that we respond to the environment? And how is it that environments modifies the expression of genes in the brain? This is one of such studies that, for example, illustrates a very important component. This study is looking at how the morphology, the structure, the volumes of our brain change through childhood and adolescence, age 5 to 17. And here in red, basically the color scale here indicates the influence of heritability in the modifications that occur with aging. As we age from age 5 to 17, the brain grows, but it grows in different levels. And the way that the different areas of the brain grow to different ages is also differentially affected by your genetics and your environment, which are two factors that contribute to heritability. The heritability is a measure of the similarity that exists in a parameter, in this case, brain morphology, between identical twins, which share all of their genes, and discordant twins that share half of their genes, but share basically similar environments. One can use this strategy to separate the components that are associated with genetics versus those that are associated with environment. And when the researchers did this, something extremely interesting appears that has been noted by other researchers since then. And that is that the environmental influence on brain volume and development, in this case, actually has a very, very prominent effect at age 5, 8, and through 11. And then it continues to have an effect, but it's much less so. Genetics also influence, have a large influence, but their effects are actually much more homogeneous than those that we observe with respect to the environment, where the main impact as it relates to brain structure and development is during the early childhood. And this tells us something very interesting, that the environment the child lives on, certainly from birth into at least early adolescence, influences significantly how that brain develops. So the implications are two, that if you are born in an adverse environment, that explains why it has such a negative outcome on children that we know all along. And one of the most studied areas is that of how adverse childhood environmental exposures negatively influence brain development and mental health. But the second implications are, because of this plasticity, it becomes crucial that we intervene with prevention efforts during this time period, supporting the likelihood that that child would have an optimal development. Taking advantage of, because of the importance of this, we have basically built up two large cohorts, longitudinal studies, to investigate in much greater detail to what has been possible until now, the development of the human brain. One of them was initiated between age 9 to 10 and follows these young adolescents until a young adulthood, periodically imaging them and assessing their cognition. And the other one, which we initiated last year, that aims to do a similar study, but starting in infancy. The study that initiated in adolescence, that goes by the title of Adolescent Brain Development and Cognition, has actually already started to illuminate how social adverse environments negatively influence the human brain. In this particular study, for example, we see that family income, that is, the income of the children on the families that they lived on, with higher income versus lower income, has a significant effect on their cognitive performance. If they come from families with high income, their cognitive performance is much better than if they are raised in families with low income. In parallel, studies in their brains to see how they are actually developed indicates that those with high family income have higher volumes of the brain and a larger cortical thickness than those individuals that are born in families with low income. And through these studies, it is also possible to ascertain the areas of the brain that are more sensitive to these effects from income inequalities in brain development, how these income inequalities influence cognition and brain development, of course, relates to downstream consequences of not having access to high quality education, or not being the parents having to work multiple shifts and therefore are not able to actually provide that support that's necessary. And other downstream effects like lack of exposure to green spaces where they can have physical activity that are likely to negatively impact this trajectory. Importantly, it recognizes that the medial frontal areas of the brain, which are crucial for self-regulation, are some of the most affected ones by these adverse environmental exposures. So what are the implications? The implications clearly are those of prevention. And the purpose of these studies is to understand how the negative factors associated with increased risk for addiction, influence the brain negatively, producing addiction in such a way that the prevention aims to decrease these risk factors, while on the other hand, enhancing those protective factors to provide with multiple pronged approaches to address the likelihood that an individual, either with no risk or with excess risk, can prevent substance use and addiction. And these prevention interventions actually are based on individual interventions, such as, for example, in those children with poor self-regulation or with early evidence of aggressive disorders or with the early evidence of mental disorders that put them at higher risk of drug use, to familial ones to actually provide support to families so that they can learn how to empower their children and give them the tools to actually navigate peers where they may be exposed to drugs. Similarly, the school can play an extremely important role in providing prevention interventions to teach skills to children to actually navigate peer pressure to the use of drugs. And ultimately, communities themselves, by providing alternative supportive environments, can play an important role in providing resilience. And this is an example about how prevention interventions work. And they have been shown, these prevention interventions that target both the individual. This is an example that targets both the individuals as well as the parents. And this was an intervention done in the Black American families that were in poverty. That what it did was support the adolescents when they were 11 to 12 years old and the families, and then actually monitor their behaviors and their brain in this case when they were young adults. And it shows that this intervention mitigated the effects of poverty that you see in those that were not those children that did not receive the intervention, the families. Those that did actually obviated the reduction in volume in two areas of the brain that are crucial for emotions and memory, the amygdala and the hippocampus, indicating in this study not just that you reduce drug use in these individuals as they became young adults, you improve actually overall mental health, and you actually prevented some of the adverse effects of poverty in the brain. Now, I want to jump into what has happened since the past 2.5 years, since we saw the COVID pandemic hitting the worst opioid crisis that we've ever had in the United States. And this was actually, of course, of great concern because we know that the COVID pandemic placed all of us at much greater stress and also interfere with the capacity of the healthcare system to provide with the support that people that are taking drugs or have a substance use disorder require in order to actually improve their outcomes. And so it was not surprising to actually realize with the COVID pandemic there was during the first year a 30% increase in overdose deaths recorded that then subsequently from the second year of the COVID pandemic resulted in a 15% further increase. Thus, we have been, since the COVID pandemic, there's been close to a 50% rise in overdose mortality in our country. And this reflects two large cluster of factors that are driving it. One of them has to do, as I mentioned, with the stressors that we know are key components in contributing to drug use in general, to escalating drug use among those that are already taking drugs, and to relapse for those that are in recovery. So that's one element. And the other one has to do with the characteristics of the illicit drug market. And this is sort of illustrated in here, where we see for the data from the latest data that we have from the CDC that ends on December 2021. And it reports the number of deaths that preceded in the preceding 12 months as compared to the number of deaths in the preceding 12 months of 2020, the first year of the COVID pandemic, when we saw that jump of 30,000 deaths. And you can see that despite this very high level of overdoses, there was a 15% rise, a further rise, that is driven not by heroin. In fact, heroin overdose deaths has been going down in our country, nor is it driven by what initiated the opioid crisis, which has prescription opioids. Those have been quite stable, nor has it been driven by methadone, which actually was liberalized with the COVID pandemic, which led some to believe that it could lead to misdiversion of methadone and overdose death. That did not materialize. On the other hand, we're seeing the rise driven by synthetic opioids, predominantly fentanyl, methamphetamine, and to a lesser extent, though contributing importantly, cocaine. So these are the stimulant drugs, and these are fentanyl. And fentanyl is the main driver. And 75% of overdose deaths from cocaine contain fentanyl, and more than 60% of overdose deaths from methamphetamine contain fentanyl. So like illicit drug market has changed dramatically, and more we see contamination of cocaine, methamphetamine, and other drugs by fentanyl. So this is one of the components I was just mentioning. On the one hand, all of the changes and stress that happened with the COVID pandemic, as well as the social structural components that actually make it very hard for people with a substance use disorder to receive treatment, retain treatment, and that actually promotes to their stigmatizations, like the criminalization of individuals that are taking drugs, the greater likelihood of these individuals ending up in homeless or in shelters, all of which, of course, make it much harder for them to seek out treatment, to receive it, and to be retained in treatment. But the other element that contributed to that very significant rise was, as I mentioned, the illicit drug market. As you can see here, and this is data from 2014 to 2020, that actually is summarizing the seizures of different types of drugs during that time period. And we can see that for the first year of the pandemic, and this has continued and actually accelerated for 2021, there's been a significant rise in the seizures from methamphetamine. Look at the very high jump, and importantly, fentanyl. And fentanyl has been rising since 2015, but the rise that it goes from 2019 to 2020 is much greater. And so was the rise that I'm not showing you here from 2021 to 2022. So this is the main culprit alongside the significant increase and expansion of access to methamphetamine in our country. And again, the increased contamination of methamphetamine, cocaine, heroin with fentanyl. What we do, so what is it that we are doing all along, and what are the tools that we have to address these overdose crisis? We know that one of the most powerful interventions that we have is to expand the access of naloxone in order to be able to reverse overdoses. Naloxone is quite effective in reversing overdoses, even those from fentanyl, provided that the naloxone be administered promptly at the adequate doses, and in some instances, it may require repeated dosing. The reversal and overdose provides an opportunity for that individual to be brought into treatment, which of course is the ideal ultimate goal. But not all of the patients are ready to actually address going into the treatment, and therefore the importance of expanding access to naloxone, because you save the life of the individual. And in the process, you gain time so for that individual to actually ultimately reach out for treatment. In treatment for opioid use disorder, we have quite effective medications. We have buprenorphine, methadone, and naltrexone. All of them are effective, and the National Academy of Medicine had a report that actually stated that this should be the first line of treatment for opioid use disorder, and that this treatment should be provided even when the behavioral support systems that were required in the past are not accessible. In other words, medications for opioid use disorder are beneficial even in those instances when it's not possible to provide the aleatory and, of course, ideal behavioral support treatment for that individuals. Now, into the right, I just show you the recent data indicating how effective are medications for opioid use disorder for treating the condition. And in this particular case, the data that you're seeing is the effectiveness of medications for opioid use disorder in preventing non-fatal overdoses among pregnant women. And it shows, depending on how long the medication is sustained by these pregnant women throughout their pregnancy, you can see that the significantly higher level of protection. For those women that actually are on medications for the whole, basically most of their pregnancy, the protection is almost complete in preventing them from overdosing. But even if it is not sustained all throughout, it provides a significant advantage. So what does this data tell us? Well, the data tell us that it is crucial that we expand access to medications for opioid use disorder and that we sustain treatment on those on medications for opioid use disorder as long as possible until they achieve recovery, because that's going to protect them the most against overdosing. But there are major challenges, and we need to be aware of them. And one of them is indicated here, and this is data from SAMHSA for their yearly survey that indicates that only 18% of individuals that could benefit from a medication for an opioid use disorder actually receive it. So we need to expand and provide treatment, accessible treatment for people so that they can be initiated. But importantly, as I just mentioned before, we need to retain them in treatment. And this is a recent meta-analysis basically identifying the range of retention for different time periods for the different medications that we currently have. And what is clear overall is that there is between a 50 to a 60% retention at 6 months of initiation. And thus a major challenge is what is it that we can do to improve and enhance retention, as well what is it crucial that we can do to expand and initiate treatment for individuals with an opioid use disorder. And this brings us to an important component of our research portfolio, and that is implementations and services research. We know that medications for opioid use disorder work, we know that, but we know that there are major challenges in implementing it. So what we have done is we have built 3 large infrastructures to enable us to take advantage of systems that exist in our society to create models for them to be able to provide those medications. One of them is the healthcare system, which we actually study and implement through the clinical trial networks, the CTN at NIDA. The other one is the justice settings, which are important because a significant portion of individuals with substance use disorder, including those with opioid use disorder, end up in prisons and jails or are part of the justice parole system. And there is therefore a unique opportunity to initiate treatment in these individuals. And finally, we generated a large cohort of communities that goes by the term of the healing community studies in 4 of the states with the highest mortality on overdose deaths, to actually generate a model about how the healthcare, justice, and community can partner with the states in order to be able to provide the treatments and the evidence-based prevention that can help those communities overcome overdoses. Through these large networks that researchers basically place researchers to interact with providers and with those suffering from the disease with lived experiences and their families, we've been able to, for example, accelerate our understanding about the models that can be utilized for implementing medications for opioid use disorder in healthcare. For example, this is one of such examples from the CTN, which has played a lead role to showing that physicians, emergency department physicians, as well as assistant physicians, can play an important role initiating buprenorphine treatment in the emergency department, which patients that are brought there following an overdose or intoxicated. And these studies have shown that it's not just safe to do so, but it significantly improves the likelihood that these individuals will stay in treatment and actually will decrease their use of opioids. These interventions are also cost-effective and decrease the likelihood of those individuals accessing emergency departments into the future. Through the Adjunctive Innovation Network, we have also been able to fund studies that show how the implementation of buprenorphine treatment in jail, between two jails, comparing one that initiated buprenorphine in jail versus one county jail that did not initiate buprenorphine, how the outcomes are much better for the jail that was able to initiate buprenorphine than that did not, as it relates to much lower rates of recidivism, much lower rates of rearrangement, and much lower rates of reincarceration. Through the use of this network, we have also been able to implement randomized clinical trials that document the optimal way of intervening to improve the outcomes of those that are incarcerated. In this case, for example, this study compares just the administration of buprenorphine, like was given in the Franklin County Jail, which was just the regular use of buprenorphine, in this case, 1 month before release, versus a new formulation of buprenorphine that actually requires only once a month injection, making it much easier for the jails and making it much easier for the patients themselves to sustain treatment. And that very simple innovation, extended release buprenorphine, injectable buprenorphine, significantly improved outcomes. And that related not just on improved retention in treatment, but also significantly reducing the use of opioids, as well as significantly reducing the rate of reincarceration. Noting again that you are comparing against buprenorphine that significantly overall by itself improves outcomes. And exemplifying how we can use innovation and science to come up with solutions that are easier to implement in unique settings like jails and prisons. In parallel, we've also are funding research that is transformative on the way that we treat substance use disorders, so that we can provide other opportunities and ideally, ultimately personalized intervention. I have here some of the examples. There's a lot of interest on research ongoing in immunotherapy, whether it is vaccines or passive immunization with antibodies for drugs like methamphetamine, fentanyl, and heroin, whose function is to actually have antibodies in the bloodstream that capture the drug so the drug cannot enter into the brain. There are ongoing clinical studies currently being done with methamphetamine that look actually quite promising. There are several studies ongoing too to evaluate the use of neuromodulation technologies that can rely on transcranial magnetic stimulation, transcranial direct current stimulation, that can rely on ultrasound, or even invasive procedures like deep brain stimulation for the treatment of substance use disorders. And these interventions are based on our understanding of the neurocircuitry that is affected by the use of drugs, and how the weakening of those neurocircuits, or actually sensitization, results in the addiction cycle. With that understanding, we can actually strengthen those processes that are weakened by drugs while actually reducing those that are sensitized. We have also been able to launch research to understand how the policies that were implemented during the COVID emergency, both for methadone and buprenorphine, ultimately influencing outcomes, including whether there was any evidence of increased overdoses from the facilitated use of buprenorphine or the take-home methadone that happened during March of 2020. The data show there's no evidence that these changes in the way that buprenorphine and methadone were administered to patients that need them were involved increased overdoses from the use of these medications. In turn, data is starting to show, and this is a study from Canada, that indeed individuals that were given methadone to take home for 4 or 5 days, which are these ones on the light colors, are actually much more likely to remain in therapy, much less likely to interrupt therapy, and much less likely to have overdoses than those individuals in the methadone clinic that were required to go in on a daily basis, highlighting what already we have heard from many of the users of the methadone clinics, that one of the challenges for many of them is the need to go on a daily basis. And then missing 1 day of dosing can result in tragic consequences. And for the end of my talk, I want to actually give the projection of where we are with the overdose crisis and where we need to go. This is on 2020, just as the COVID pandemic was hitting us. And it was on 2021 when we actually documented more than 100,000 deaths on any 1 year. And those, as I was mentioning earlier, those overdose deaths are very much driven, the acceleration by fentanyl. But when you look at the curves of the stimulant overdose deaths, we're seeing that they are also significant contributors. And what it is telling us is that in the past, whereas people that were using stimulants were not at very high risk of overdose, that has changed since 2015 when fentanyl entered the market, presumably, mostly because many of these stimulant drugs are now contaminated with fentanyl, or perhaps also in some instances, because individuals that are taking stimulants may also be seeking out consumption alongside opioids. Also, the divergence in those that become vulnerable was made evident by a publication that came up a couple of months ago that showed for the first time a phenomena that we had not seen in the United States, and that is an increase in overdose fatalities in adolescents from fentanyl. In the yellow lines, and this is data from 2015 to 2022, in adolescents 15 to 29 years of age, in the orange line, you can see that the overdoses overall have been going down for all of the drugs that we were monitoring, presumably because during this time period, we have seen a significant reduction in consumption of illicit drugs, basically whether it is heroin, cocaine, or methamphetamine, among teenagers. On the other hand, look at the rise in overdoses from fentanyl. And we see this rise is becoming evident in 2016 when we start to see overall an increase in fentanyl overdoses in the adult population, but it becomes actually worse in the year that precedes the pandemic, and then it continues to go up. Now we know that heroin use among teenagers is extremely low, the lowest it has been since we have been recording it in monitoring the future. We also know, as I mentioned, that the prevalence of cocaine and methamphetamine in use is at its lowest. And teenagers don't consume fentanyl, but what they do consume alcohol, they do consume marijuana, they do consume vaping, they vape, and they also consume misuse prescription drugs. Among the prescription drugs that they misuse are stimulant drugs. They misuse opioid analgesics. They misuse prescriptions, anxiolytics, benzodiazepines. Those are their favorite. And what has happened in the United States, and this is data from 2018 to 2021, also showing drug seizures, is that the number of illicit manufactured pills in the United States, the number of seizures detected, that contain fentanyl has risen from 280,000 seizures in 2018 to 9,700,000, close to that. This is basically a fourfold increase, which means that the likelihood of being exposed to a prescription drug that is bought in the illicit market that contains fentanyl is much higher now than it was 3 years ago. And this is likely to account for why teenagers are now being have an increased rise in overdose deaths from fentanyl. And it is this danger and expansion of illicit prescription pills with fentanyl that is also likely to put at risk for overdose individuals that may be occasional misusers of drugs like benzodiazepines that they may buy in the illicit market because they are anxious, they cannot fall asleep, or stimulant medications to help them actually with their inability to focus when they cannot get these medications from their prescriber, or either to illicit prescription opioids because they have pain and also they cannot get it from their physicians. These individuals that in the past were not at risk of overdose are now at a much higher risk based on the changes in the illicit market. So what does this tell us as we're thinking in terms of where do we go for addressing the overdose crisis? Well, number one, the overdose crisis started with the improper management of pain patients and with the overprescription of opioid medications. The need of patients with pain, severe pain, is still there. And it highlights that we need to continue to develop research and interventions and support for those patients. Because if we don't do it, they'll go into the illicit drug market, which will put them at higher risk of overdose. But just focusing on pain patients is insufficient to address the overdose crisis. In the past, also, we were very aware that individuals with an opioid use disorder were the ones that were at greater risk. And thus, providing them with treatment for their opioid use disorder and sustaining them in treatment continues to be perhaps one of the most important interventions that we can do for addressing the overdose crisis. But it's also not sufficient. As we're seeing more people with stimulants use dying from overdoses, it does highlight that need to also expand treatment for other substance use disorder in order to address the overdose crisis. It's also clear that more and more people are dying from multiple use of drugs at the same time. And whereas in the past, reversal of an opioid overdose with naloxone may have been sufficient, it is less likely that it is as effective when someone has a combined opioid and stimulant overdose. And finally, I would say that perhaps the most important thing that we also need to do at this moment is step back and look at the notion about we have known all along in medicine that prevention is probably the most impactful intervention that we can have, and that we need to give it a priority that it deserves. We have gone from one crisis to the other because we have basically tailored intervention to one condition. We know that right now it is more urgent than ever to do prevention interventions that will help and actually avoid an overdose from someone that may be experimenting with drugs, to prevention interventions that may help someone not escalate into more dangerous drug use, or that may do an intervention to bring them to treatment. Prevention works and is likely to actually, at this point, more than ever, because of the danger of the currently available illicit drugs for overdoses, more important than it has been in the past. And with that, I want to thank you for your attention, and I look forward to the opportunity to meeting all of you in person.